Good afternoon to those of you on the East Coast and here in the Midwest, and good morning still to those of you to our west. I'm Katie Hilton, and I have Briar Andreessen and Steve Beck, my colleagues here, to talk about advanced provider-based issues and current enforcement trends. A couple housekeeping notes before we get started. The next Health Law webinar will be, as always, the second Wednesday of the month. It will be May 11th, and we will have our colleagues Ryan Johnson and Catherine London, our experts in telemedicine and telehealth, on for that hour to talk about regulatory and transactional issues surrounding telehealth. So that's bound to be a great hour. And then we would also solicit your ideas for future Health Law webinars. We do look at your comments, and so please also comment on this webinar, but we're always looking for ideas that will be entertaining and useful to you. Maybe not entertaining at all times, but at least useful. If you do experience sound issues as the presentation goes on, there is a dial-in number that Robert has sent out in the chat box. And the internet can be slow at various places over the noon hour, and so you can feel free to dial in. We ask that you don't dial in unless you need to, because we do have to pay for that on a per-click basis. And then if you have questions, please do use the chat box on the lower right-hand corner. All right, so just a basic overview. Briar is going to, who is probably our best provider-based lawyer, has worked with these issues for a long time, is going to talk very briefly about basics, how we got to where we are, and then the sunset rules. Then we're going to go into these current topics for enforcement and investigation areas, and then take some questions at the end.
All right, thanks, Katie, and thanks for reading that note that I wrote on your sheet about me being the best provider-based lawyer here.
Thanks for the money.
So I'm just going to talk a little bit about basics because I assume that everybody on this call already knows most of this stuff, but the provider-based rules are found at 42 CFR 41365, and under those regulations, hospitals can treat some of their facilities and locations as part of the hospital for Medicare payment purposes. The big key is that the location has to be an integral and subordinate part of the hospital. The big advantage to provider-based status is that it's mostly better reimbursement. For Medicare purposes, you do get a facility fee. There's a somewhat lower physician fee schedule payment when there is provider-based location, but it is more than offset by that facility fee. One downside is that patients generally pay more. They have to pay two copays, one on the facility fee and one on the other charge. And then, of course, not all payers recognize provider-based status, so this is really mostly specific to Medicare payment. There are some 340B advantages, and I believe Katie's going to be talking about that. And there are different requirements for on-campus locations versus off-campus locations. Some of those are related to patient awareness of their co-payment obligations, and then there are some ownership and reporting issues as well. So, excuse me, these regulations implement certain statutory provisions. There's a little guidance that's out there from CMS. There's a very little bit of case law, which we'll talk about later. And what the statute describes is payment for covered outpatient department services. So, with that said, kind of since the beginning, there have been grumblings and complaints about provider-based status, and the writing has been on the wall for a while now about provider-based status going away, and that's been a threat for a while. The government has been telegraphing this. MedPAC has for a while been looking for site-neutral payments with provider-based and otherwise. There's been a general unhappiness that E&M services get paid more in an outpatient department than they would in a regular physician clinic. And that's kind of general unhappiness from the government, but also patients are sometimes very irritated with that, that some services that they had received at a physician clinic are all of a sudden costing them a lot more. So there are going to be some changes. We will discuss them, and the proposed changes would apparently save about $10 billion over 10 years, so not pocket change. And since 2014, the government has been requiring submission of data on where outpatient services were furnished so that CMS could figure out what services were happening where. And this also was some writing on the wall because they were trying to get a handle on how much extra they might be paying. So very recent developments, the 2016 OIG work plan includes a review of compliance with provider-based requirements. So they are going to be looking at whether locations are doing what they're supposed to be doing with regard to their provider-based obligations. As of 2016, the claims from off-campus departments also have to include that HCPCS modifier of PO. And as always, the physician services have to include the appropriate place of service, either on campus or off campus. The big change that I'm going to be talking about is the sunset provision of provider-based status. And you may hear this referred to occasionally as Section 603. That is because it was Section 603 of the Bipartisan Budget Act of 2015, titled Treatment of Off-Campus Outpatient Departments of a Provider. And this became law on November 2, 2015, which, as we'll see later, becomes a very important date. So what the law says is, as of January 1, 2017, no payment of facility fees for services in new off-campus departments of providers are going to be paid. The rule, the sunset provisions, this Section 603 does not eliminate provider-based status. It doesn't prevent acquisition of provider-based departments. Those regulations that implement the provider-based requirements are still in effect. 603 just amends the statute. And again, this only applies to off-campus departments, not on-campus departments and not remote locations of a hospital. So again, Section 603 says items and services furnished on or after January 1, 2017 in new off-campus outpatient departments of a provider will not be paid under the outpatient prospective payment system. Instead, they get paid under whatever other payment system happens to apply. Generally, this is probably going to be the physician fee schedule, but there might be other possibilities too, ASC or other options. Section 603 removes from the statutory definition of a, quote, covered outpatient department service items and services furnished on or after January 1, 2017 by an off-campus outpatient department of provider. So this clearly makes the determination of whether something is off-campus a bigger deal. And we'll discuss that in a lot more detail, Steve will, later on in this webinar. So Section 603 does, one tiny benefit is it defines off-campus outpatient in a way that is a little bit more expansive than the current regulations. It's anything within 250 yards of the main buildings, that's in the regs, but also anything within 250 yards of a remote location of a hospital. Section 603 does have some exceptions to this general prohibition on considering the off-campus stuff to be no longer an outpatient service, including items and services provided by dedicated emergency departments. So one question is, can you make yourself into a dedicated emergency department? And do you want to? Because there are obviously some issues that go along with that. There's also an exception for departments that were billing under the outpatient prospective payment system prior to the date of this law, so prior to November 2, 2015. And then there are also critical access hospitals and rural health clinics are not affected by this either. But apparently, if you started billing as a provider-based department on November 3rd, 2015, you are going to be out of luck as of January 1, 2017. So one more provision of Section 603, hospitals are required by this new statutory provision to provide information to the Secretary to allow appropriate implementation of the sunset provision. So they'll have to provide information with codes and modifiers and noting their off-campus departments on the Medicare enrollment forms. One big problem with Section 603 is that they cut you off from arguing about this, which makes all of us lawyers very sad. But what the statute says is that there is no administrative or judicial review under these other provisions or otherwise. So they're really cutting you off from any way to argue about this. And you are not allowed to argue about applicable items or services, so anything other than the items and services in a dedicated ED. and any other applicable payment system, so whether it's paid under the physician fee schedule or some other payment system. You also can't fight with them about whether a department of provider meets the term described in subparagraph B, which is whether it is off-campus or on-campus. I would say that the regulations are a little, they're not as clear as they might be, and so I wonder if there is some ambiguity to fight about some of the regulatory language, but that could be an uphill battle. You're also not allowed to fight with them about the information that hospitals are required to report, which the language there is taken from the statute, can include reporting of information on a hospital claim using codes and modifiers, and reporting information about off-campus outpatient departments. So there are still some questions. Grandfathering does not seem to apply to any underdevelopment departments or any contractual obligations that there might be. It's possible that there would be a fix to this in 2017, but it would take Congress or CMS to act, and probably Congress to change that statutory language. It's also not clear if there is a fix, what would be included. So, you know, there are some questions that are out there, even if there is no grandfathering fix. Some questions about whether a provider could add square footage to an off-campus department or change the existing services provided there. Whether a provider could acquire a location that already had grandfathered status, or whether a provider could have a new location for a provider-based department that had been out there but was moving to a new spot. And I would argue probably yes for all of those. That is maybe a little bit aggressive, and so the conservative position would be to probably wait on any big changes to your current provider-based departments until we have a little bit more information from CMS or government in general. But I do think that there is going to be more to come on this. There was a February letter from the American Hospital Association that was written by the chair of the Committee on Energy and Commerce and the chair of the Subcommittee on Health. And they brought forth a lot of issues with Section 603 and site-neutral payments in general, and expressed their displeasure about these things. They specifically called out that there should be some measure for those entities that had facilities under development. They want some grandfathering of some kind, and so I would expect that that is likely to happen. They also pointed out that this could significantly affect rural areas, which are probably going to be less likely to get outpatient centers since they cannot be opened off campus anymore. And they pointed out that it does lock hospitals into what they have now. It would be more difficult for them to expand new services if they can't, for whatever reason, expand on campus, whether it's because they are locked in because they're in an urban area, or they are next to wetlands, or for whatever other reasons, they're not allowed to open anything else up. So those are the issues that were pointed out in that letter, so possibly signaling future congressional action. There's also there will be proposed rules on the outpatient prospective payment system for 2017. CMS has said that they are planning to address some of this, and those rules are expected to come out in July of 2016 sometime. And they have said that you can send feedback to CMS by using the email address that is there on your screen. They've said that CMS has said they're interested in specific scenarios and questions that providers may have regarding the PO modifier, but also payments at provider-based departments. So you can send stuff to that email address. They are extremely unlikely to respond to you. And they may have even said we will not be responding because they are in the rulemaking process and don't want to muck that up, apparently. And with that, I will turn it over to Katie to talk about some current enforcement areas.
Thanks, Briar. I would say on the last slide where Briar talked about giving feedback, one area where you may want to think about trying to get a critical mass to give feedback to CMS is in the 340B context. Right now, provider-based departments can be part of the hospital that gets 340B pricing, and if there is a decrease in the number of provider-based departments and the future of those, being able to develop those going forward, then that would affect your ability to get 340B pricing. There's proposed 340B guidance that came out, I think, in September or August of last year. It has not been finalized. I think it came out, though, before we knew about these more significant proposed developments with sunsetting on provider-based rules. So it would be worthwhile to sort of join those two issues together, because I do think it could affect negatively drug pricing if the sunset rules and provider-based is eliminated eventually. So definitely comment on that. And if we get enough people to comment, then they will at least maybe address it in the preamble to the proposed and final rules. So let's move to some areas where we've seen CMS and their regional offices coming down on providers for provider-based issues. We'll talk within these three topics. They're sort of mini topics, but we're going to talk generally about shared space, about the weirdo universe of what is under arrangements and how does it cross over with provider-based. Steve is lucky enough to get to talk about that. And then we'll talk about some discrepancies in location as you argue with CMS about where things are situated and how that affects your provider-based status. So just very generally, if you're out of compliance with the provider-based status, you can see the government really go two ways, or maybe both. The first would be that you have been overpaid a facility fee for your departments or facilities that did not meet the provider-based rules. You could also see CMS or one of the accrediting bodies say that you are in violation of your conditions of participation, which wouldn't be recovery of funds would not be the remedy for that. It would be jeopardizing your provider agreement or maybe accreditation status. So that's a different type of but also scary issue. And then certainly this issue of the fact that if you know you have a provider-based department that is indeed clearly out of compliance, do you then have you retain some sort of overpayment, which after 60 days turns into a reverse false claim. So not to be taken lightly. The first issue that we'll talk about is probably one that you've been hearing buzz about as of late, and it's this shared space issue. So CMS has really taken an interest, just to give you a timeline, the provider-based rules were initially passed in 2000, and the CMS position on shared space has evolved to become more draconian since that time. And just in the last few years, it seems we've seen more focus, and then in the last maybe just year, been more news stories on shared space issues. I do know of one or two reports, just from a journalistic perspective, about CMS apparently instructing its contractors and educating surveyors and accrediting agencies on its own doctrine on shared space. I don't know if that has actually happened, but that's certainly been in the news. Be very curious to know if anyone knows sort of has some primary information on that. We have definitely, though, seen more investigations of this anecdotally, at least in our practice. So first thing you always want to do when you're being investigated for something is to figure out what the heck the law is. And in this case, it doesn't really seem like CMS has looked at that question very well. As Breyer pointed out, the provider-based rules are actually regulations. There isn't a statute on provider-based anything. So you can skip the Social Security Act, and in fact there is only one regulation, as long as it may be, 41365. Preamble language, of course, to the initial rule and then any updates. So there have been a few Federal Register issuances. I think maybe only, of consequence, only 2, maybe 3. There is a state operations manual section that talks about surveyors looking at provider-based issues. I don't actually think it says anything about shared space expressly. And then there is a program memorandum from just a couple years after the rule was passed clarifying some issues. But again, I don't think really addressing the shared space issue. So knowing that the regulation does not expressly say anything about whether you can or cannot share space is a giant, I guess, red flag to me when I know that the government is trying to enforce overpayment determinations against entities based on shared space, because there is no actual law that prohibits it. The only indication we have, at least at the beginning of when the rule came out, was the Federal Register language from 2000, which said, actually did not have a disfavorable or unfavorable view of shared space. A commenter had asked if a clinic space could be shared by two clinics, one of which is provider-based and one of which is freestanding, without impacting the provider-based status of the first clinic. And CMS said, the question regarding sharing of space can be answered only in the context of a specific case, and we expect that such decisions will be made by our regional offices. So again, it was a case-by-case determination, not necessarily a prohibition, and one that would presumably look at the facts and circumstances of each case and not issue sort of general blanket rules about what's good and bad with regard to shared space. So can you actually do this? Can you have a provider-based, can you have a freestanding facility or space in a hospital space? The central office and then we know of two regional offices that have said no, and I think that's probably actually broader than that in terms of the number of offices who are saying no. And we have some insight into these regional offices' positions based on letters that have gone out to hospitals, and I think both letters that we know of have basically said to the hospital, there is space that is freestanding and there is space and it is shared in a hospital space. We think that this violates the provider-based rules, and therefore we are making an initial determination that you've been overpaid. And so these letters have gone out in the overpayment context. I don't know, we don't know whether they've been appealed or settled or what, but they are coming out in the context of something that can be appealed. So that's really important to know. There are certain things about provider-based, as Breyer foreshadowed, would not be able to be appealed, where you can't argue about things. But an initial determination where the government has said you've been overpaid is indeed something that can be appealed through the various levels up to an administrative law judge. So just because you get one of these letters doesn't mean the fight is over. Now, whether it's practical to fight is another question. Depends on your case. But I would say in the shared space context, again, there's not a law that says you can't do this. So the two letters I'll talk about are very similar. The Region 5 position was based on, I think it was a letter that went out maybe 6 years ago, so it's been several years, to a facility where there was a freestanding radiology department within the hospital. And the Region 5 office took the position that a freestanding facility doesn't meet the definition of a department. And very broadly, the rationale was kind of two bases. The first was that when you have a hospital that has a provider agreement with CMS, every part of the hospital must meet the requirements of the provider agreement. I don't actually think that's a very good rationale, because indeed the hospital was saying all parts of the hospital that we're saying are the hospital meet the provider agreement. This part doesn't, but that's rationale number one. The second is this public awareness issue, where the government believes that if someone is confused, someone can be confused, a patient can be confused by the commingling or the sharing of space of a hospital space and a freestanding facility. And if that happens, if there is confusion, apparently that means there will be, the harm is that there will be a risk of increasing program payments. Which again I find is interesting, because how is it that you can reduce the amount of provider or hospital space, and in that space the government pays out more money, they pay the facility fee. How is it that you can reduce that space by carving out a freestanding space and still have a risk of increasing program payments? It seems actually that maybe there would be more likely that the program payments would be decreased. But that is indeed the position. So what is exactly has CMS said about what you can do with regard to shared space? The region, this regional office's position started out with this notion that you could have a suite in a medical office building, and that would be what is called a singular component that could be carved out for provider-based purposes. That could be a singular component, can be freestanding. But if you then divvy up further a singular component, then you are crossing the line and sharing space inappropriately. Now, the letter went on to say that there are a couple other factors that could be problematic and cause confusion. Shared entrance, shared registration, waiting areas, going through a freestanding space to get to the hospital area, sharing staff, and also confusing signage. That's a little bit more than just having, that seems like you have to have your own singular component or suite as well as not do any of these things. But as far as I know, you could still have a suite in an office building that is recognized by the Postal Service as a unit, but also have shared waiting areas. So the letter continues to sort of creep along as to the things that this particular regional office won't like. And then we kind of get into bizarro land, where we see some more factors that this particular person might look at. And if you have building plans that don't clearly demarcate a purported hospital space as a distinct space, then that is a negative for you. Again, I'm not sure what sort of building plans they're looking for, and I'm not sure what sort of architectural drawings actually demarcate things and label them as hospital or not, but that's one, I guess, idea out there. And then there is this notion in the sort of the latter half of the paragraph that suggests you cannot sublease space. Even if it is a singular component, even if it is a suite that you rent, you could not sublease the space to a tenant. Rather, that person would have to be paying the landlord. So kind of some just weird creeping ideas in that particular letter. Again, as I would say, not supported by any statute or rule, or even official program guidance. The Region 8 position is very similar. There was some press about this. There were a few specialty physicians renting medical space from a hospital, and CMS did not like that. In the position, they reiterated that they wanted to have an exclusive entrance. Now that's different, I think, than what we've seen before. Exclusive waiting and registration areas, permanent walls, and then again the suite recognized by the U.S. Postal Service. And then again we see the similar factors in red that we saw in the Region 5 position. But they really don't like this portioning off of space to be provided to a medical provider or a physician. So as I said, each letter was an initial determination, and there was an opportunity for the hospital to fight back, and I frankly would have fought back very hard on this. I'm not sure if they did and what the outcome was, but it would be difficult, I think, for someone to articulate, for CMS to articulate to an administrative law judge that there was some sort of clear law on this topic, because it just isn't there. And we've also seen this issue of shared space being manifested in attestations being denied. That's a little bit harder because you can't necessarily appeal that. I think that's right. I'm looking at my colleagues. And so then the question is, what do you do about this? What do you do if you have it, and what do you do if you want to do it going forward?
So this is a moment when we can banter back and forth among the lawyers and talk about what on earth we would do. And I think that there will be a number of questions that would come up. The first question is, if you have a provider-based space, do you want to do an attestation? That's really a decision that needs to be made actively. And I think this is a worthwhile point because there are lots of folks out there that simply decide to do an attestation, assign the project to somebody in their compliance group or their billing group, and put something together. There's a question whether you want to do that. Because the attestations are not reviewable, and because the government has an interest in kind of pushing this shared space position, they will likely take a much more aggressive view in an attestation than they would have to, or than in another context. And so we don't really know when they might think something is shared space. To the extent that there's any kind of freestanding something that's close by, there ought to be a conversation about whether an attestation makes sense or not, and there could be lots of things that go into that.
We think we've seen their definition of shared space evolve, or at least the scope of what they think is problematic evolve from the maybe closer calls where we had mixing emergency departments rooms with urgent care rooms or waiting rooms, or exam rooms for non-hospital services, and even mixing them on a time basis where certain spaces weren't used all the time for hospital space and other times they were. That would still probably be a closer call, but what we've seen CMS, originally take issue more with those sorts of fact patterns and then move to just plain a physician renting a space exclusively for full-time within a hospital building.
And we had a question just come in about whether this material applies to a physician practice. And I mean, the provider-based rules are really intended to direct how hospitals bill for things, but certainly they could affect an independent physician practice who has a joint venture with the hospital, which really can only be on campus. But also that can come up in the space sharing area, because a physician office may rent space within the hospital, which generally should be okay, but that technically, I think, would be considered to be shared space for CMS purposes now. And so even there, the hospital will need to be very careful about how that space is presented to the public. And if the physician also wants to have space within the hospital to do some provider-based stuff and get in on this facility fee action, then there's going to be a watchful eye from CMS for that type of thing as well.
I think that one of the things that we can take away from this is just that CMS really hates provider-based clinics, and they particularly hate the idea that something that has operated separately as a physician clinic and billed under the physician fee schedule is converting to be provider-based and bill as a hospital outpatient department. And they're going to be very negative on that, and they're going to certainly scrutinize issues like, does this look like the hospital, or does it look like it always looked like a freestanding clinic? Mm-hmm. Well, let me move on because there is another way, and there's another thing out there, and it's called under arrangements. And in order to talk about under arrangements, we have to take a deep breath and then go back into ancient history and talk about really what provider-based and under arrangements mean. A provider-based entity or department is part of the hospital. It's the old definition before they came out with this more complex rule was simply that it had to be a subordinate and integral part of the hospital. And that existed back in time, and at the same time there was a concept called under arrangements, which meant that the hospital could deliver services directly, or it could contract with an outside party, and the outside party could deliver the services, and they could be billed by the hospital under the normal hospital billing mechanisms. So why did we have these two things? Why can you bill the same way if you are part of the hospital as you bill if you are something that the hospital is merely contracting with? And I think the difference goes back to cost-based reimbursement principles, to cost finding. I think that in the old days, a provider-based entity was a part of the hospital, and so there was an allocation of the hospital's central overhead costs to that department. It would be a billable cost center, and there would be cost reimbursement that would apply. Whereas under arrangement services would simply report their outside costs, and there'd be some limits that would apply to the outside costs. So there were two concepts that worked differently, and there were somewhat different outcomes under cost reimbursement principles. Now, for lots of hospitals out there, cost reimbursement is almost dead. Critical access hospitals still operate under cost-finding principles. And so the original purpose of provider-based and under arrangements as kind of two options for hospital billing still make more sense for a critical access hospital. But I think that's the context that lets us sort of understand why under arrangements exists and why under arrangements will probably continue to exist. It's ensconced in the statute in a way that provider-based actually isn't. Hospitals are, as part of the Medicare benefit, permitted to provide certain services and bill for certain services, whether they provide them directly or under arrangements with others. So there have been an increasing number of reasons why the idea of under arrangements has become important, become increasingly important over the last few years. And so here are a few of them on this slide that are important. The ACA came out a couple of years ago, and it said we're going to get rid of physician-owned hospitals, and they did it by changing the Stark law exception for physician-owned hospitals and the rural exception in Stark, so that ownership of a hospital wasn't permitted. Or the reality is it is permitted, but with significant restrictions that are put on the hospital. The hospital basically can't expand unless it meets specific requirements and gets approval. So something that folks don't necessarily know is that if you have a physician, a joint ventured department, a joint ventured provider-based department, that is considered physician ownership, and the Stark law is going to create the grandfathering restriction on growth for the hospital. There is, however, a specific exception that says under arrangements, that is not the case. Under arrangements is a free pass on physician ownership. So you could have a joint venture or simply a physician-owned entity, and that thing could be hired by the hospital to provide a service, and the hospital could bill for the service as a physician service. And so that's one reason why the law has moved in a direction to cause us to distinguish between provider-based and under arrangements and make an active decision which one's better. Second thing that happened not too long ago is a little bit similar to this new prohibition on off-campus provider-based. For critical access hospitals, they said, we're not going to let you have any more off-campus provider-based services unless they're at least 35 miles away from the closest other hospital. So where they used to say there's a 35-mile test for whether you can be a critical access hospital in an area, but we'll relax that for in certain circumstances, and so we've got lots of critical access hospitals that are closer together than 35 miles. They said we're going to enforce that rule for off-campus provider-based services. So in effect, critical access hospitals very frequently cannot, and haven't been able to since about 2008, have an off-campus provider-based service. But they could go out and have an under-arrangement service. A third thing, provider-based rules exclude from the definition of a provider-based entity or department a department where all the services are under arrangements. This isn't as big a deal. It basically says, look, if everything you're doing is under arrangements, don't call it provider-based. It's just under arrangements. You just have to pick one if you're 100% under arrangements. Fourth thing, and this is perhaps the most important, and it harkens back to the first one, the Stark rules may prevent provider-based joint ventures differently than under arrangements joint ventures. And I think that the key to this is that if you have a provider-based joint venture where there's co-ownership by physicians and the hospital, you're going to have to meet an ownership test under Stark. And there aren't very many ownership tests left, especially for things that are considered to be part of the hospital. If you have an under arrangements agreement, Then you have a compensation arrangement, and you've got to meet a compensation arrangement exception under Stark. Now, both of these are really complicated because the Stark rules were also amended a few years ago to create a new definition of what is an entity. And that means that if you had a joint venture between a hospital and a physician group, and you had an under-arrangement agreement between the hospital and that joint venture, and the joint venture is providing 100% of the services that are being billed by the hospital under that arrangement, it may be that the joint venture is considered an entity under Stark, and so the physician's ownership also violates the ownership prohibition. An advantage, however, is that if you are an owner of something that is not a hospital, you might be able to use the rural ownership exception under Stark. Also, if you are analyzing this under Stark and saying the under arrangements agreement does not provide 100% of the services being billed for by the hospital, then you would say that joint venture is not an entity analyzed under Stark. Okay, so that was a huge mouthful.
That
And
could be like 10 law review articles,
it could,
if Steve wanted to write them,
which I
which
do
he
not.
doesn't.
What it means is the area of physician joint ventures with a hospital off campus needs to be something that you look at in detail with your lawyers and try to figure out, is one structure or another better? If you're trying to do something off campus, under arrangements is probably the only way you can do it. And if that's the case, you're going to have to meet the tests and look through the Stark law very carefully. I pushed the button and got off of that awful paragraph. So, what is required to be under arrangements? Well, the thing about this that amazed people when the provider-based rules came out and were many pages long with lots of details is, of course, under arrangements doesn't have almost anything that's required. It's really, really easy. There are a few things that need to be said. CMS has taken the position that there's some limitations on what can be under arrangements. They don't want it to be an entire department. Not clear that they have a basis for making the argument that it can't be an entire department. They would like to exclude some things that are core hospital services. For example, they would like to say you can't, under arrangements, purchase the surgery department. That's a core hospital service. It doesn't make sense that you would buy that from somebody else. Now, isn't clear what the basis is for that determination either, but it's probably one that, you know, has a strong argument. The reason I think it has a strong argument is this second little sub-point here, which is that there are some services that are specifically referenced as being providable by a hospital under arrangement. All diagnostic services, physical, occupational, speech-language pathology services are the main under arrangement services. Over the years, it's become evident that CMS has permitted lots of other services to be made under arrangements for which there is no specific statutory or regulatory language. So they have room to say this one is under arrangements and this one isn't, with regard to all those things that aren't specifically set out in the rule. So in order to be under arrangements, what really is happening is you have a contract with an outside entity, and the contract says, we, the hospital, are billing for this, we're paying you, and you do not have the right to separately bill for this service. The hospital's payment to you is in lieu of any separate billing. And then there's a short list of elements that need to be included in the arrangement, not necessarily in the contract, but included in the arrangement to show that there is a sufficient connection with the hospital. So the hospital is supposed to register the patient, use its standard admission system. It's supposed to apply the same quality controls as it would for under arrangements personnel as it would for its own employees. So it's got to be paying attention to who's providing the service. It's got to maintain the medical record. And it would do it just the same as it does its own medical record. And, of course, in the modern EHR era, that's very easy to do. it's supposed to maintain a liaison with the under arrangement entity's attending physician. Well, I think that hospitals always maintain a liaison with the attending physician. These are, after all, patients of the hospital. And then it's supposed to ensure that medical necessity is reviewed on the same basis by the UR committee, if there's one in place, as utilization is for other kinds of services. So that's really a very kind of general supervision or oversight that is provided by the hospital. If you do all those things, you should be able to be under arrangements. Oops, I'm going to push the button again. Oops, I just screwed it up. Okay. So we talked about this a little bit before, and I'm just going to reprise it. Stark Law becomes a big deal whenever you've got a physician joint venture with a hospital, because you don't want to have an ownership arrangement where there's ownership of the hospital or ownership of the entity that is serving the hospital 100%, and you don't want to have compensation that's unreasonable or that is prohibited under the Stark exceptions. So anytime you've got a physician joint venture, you need to say to yourself, is this a joint venture of an actual provider-based department, which is still permitted on campus, not permitted off campus, or is it a joint venture of an under arrangements entity, and if so, is that under arrangements entity an entity for Stark purposes, and we have to comply with an ownership exception, and is it one where there is it's clear what the compensation structure is and that it is permissible under Stark. I think there's another worthwhile thing to say in this regard, which is I know of nothing which requires the under arrangements entity to enroll in Medicare or to be able to provide the entire service. Under arrangements is that unclear a concept that it may be providing only part of the service. And if so, it arguably doesn't comply, it doesn't meet the requirements of an entity under Stark. So that issue is an issue that's very live.
All right, we're going to cruise quickly through some location points, and this is really meant to give you some tidbits or nuggets when you get the jerky letter that says you have to pay back money because you were not in the right location or you're outside some radius. Just remember a couple of these points. So the on-campus, off-campus distinction is important because off-campus provider-based departments have to do more things than on-campus provider-based departments. And so let's talk about on-campus first. The on-campus provider-based department must be on the hospital's campus, which actually is a defined term in the provider-based rule. And I've put that up there. It's the physical area adjacent to the provider's main buildings and other areas and structures that are not strictly contiguous to the main buildings, but are located within 250 yards of those main buildings, and any other areas determined on an individual case-by-case basis by the CMS regional office to be part of the provider's campus. So that is the actual rule text. I should probably have been more clear in, I will try to point out as I speak what's the rule and what's the preamble, but that's the actual rule. So first point I want to make about that is this question of what are the main buildings? Well, why do we even care? Well, because the 250-yard radius is drawn from the main buildings. Note there could be more than one main building, given there's an S on the end of main buildings in the campus definition. Also, there is no regulatory definition or even formal guidance definition from CMS about what is a main building. So that is up for grabs. I know of one hospital where CMS has said only a building that houses inpatients can be a main building. There is no regulatory support at all for that. And we've also seen to another hospital that the main building could be, a main building is one that has inpatients or significant outpatient services, whatever that means. So Breyer made the really good point the other day when we were talking about an issue about how you could have more than one main building, and then your radius gets, well, not your radius, the number of radii increases because you get to draw from what you arguably have as your main buildings. And so your campus gets bigger. So remember that point. The second point about the definition of campus, and I'll just go back if I don't screw that up. Back arrow. This is difficult for me. So going back to the rule, the regulation's actual definition of campus, you'll notice at the end that it doesn't cut off at the 250-yard limit. It also says any other areas determined on an individual case basis by the CMS regional office to be part of the campus. And so that's really good because that's in the rule. And then it's backed up by preamble language in 2000 where CMS said this definition of campus includes self-contained areas, but also areas such as those in central city areas where there may be a group of buildings that functions as a campus but are not strictly contiguous. Okay, so that could be within 250 yards. It could also be outside the 250 yards, and the regional office is going to make these determinations for the purpose of allowing CMS to take a flexible and realistic approach to the many physical configurations that hospitals and other providers can adopt. So you should use this language in your response letter that says the building you have that's more than 251 yards away could still be on campus. And you should also use the St. Vincent's case, which is a departmental appeals board case, actually from several years ago, 2008, where I believe it was a hospital in Manhattan had its sort of traditional inpatient building in one location, and then about 400 yards away in Greenwich Village, maybe, there was a cancer center, and they had attested for this on-campus status for the cancer center, and CMS denied it and cited very weird reasons like the urban nature of the area is too dense. They cannot directly see from the inpatient building to the cancer center, and there are businesses and residences along the way. No idea why those things are important. And the ALJ said, no, those aren't real reasons. You have to give reasons that relate to the purpose of the rule, and later kind of clarified that the purpose of the rule is about helping and protecting patient interests. So you have to, CMS, give a reason why denying this status to this clearly integrated campus would be helpful to patients. So that's a really good case to keep in mind. On the off-campus side of things, there is also a geographic requirement, which is that the off-campus provider-based department has to be within 35 miles of the main campus. So I guess one question for both the 250-yard requirement and the 35-mile requirement is that, do you measure that by Google Maps as you drive your car, or do you measure it as the crow flies? We've seen CMS accept as the crow flies. I don't actually know if that's in any guidance, but I think that's pretty widely accepted. So that helps a bit. So don't just get out the Google Maps. So on the off-campus issue, the question has been asked as to whether there can be more than one main campus, which would give you another point at which to begin your 35-mile radius calculation. What's interesting is that in a different context, in the physician supervision context, where they're talking about whether supervising physicians for hospital diagnostic or therapeutic services can be, where they can be, how far away they can be when supervising, there was preamble that acknowledged that a hospital could have more than one main campus. And this doesn't happen very often, but I recently worked on the merger of two hospitals, and so like a CMS certification CCN combination transaction where you have two hospital campuses now under one provider agreement. Very hard to argue that there aren't two main campuses in that context. So that's another sort of nugget of support that maybe you have more latitude than you thought. So we talked a little bit about attesting, whether to attest. I did get a question here that kind of relates to this point. The question was, it was a fact pattern about shared space. Is it okay to have two distinctly different check-in areas within the same office as long as it is clearly differentiated by signage showing one area that is in the hospital facility? They use the same waiting area. It's divided by a half wall. So I guess my point here is, I don't know that if I had this fact pattern, at this point I wouldn't go and attest because I think it would be attacked. I think there's some risk that CMS would take issue with this, but I think if you would assess that sort of from a business perspective, but I think if you have very good signage, different check-in areas, different registration areas, it seems like the only issue is the same entrance, which we've only seen brought up once. And the same waiting area is potentially an issue. So you kind of have to weigh how many factors that you've seen CMS take issue with are in one basket and how strong you feel about taking on that risk.
Yeah, I think there's a big conversation to be had with your advisors about the chance that in the attestation process, CMS is going to take an absurdly conservative position, and that, in effect, chases you away from attestation. And I think that, unfortunately, that's kind of where we'll be a lot of times.
So I think we've covered most of the questions. Oh, one point I wanted to make is a negative to doing provider-based status is that you can no longer do incident to billing as you would in the clinic. So that is a revenue issue to consider, and as provider-based might become more precarious, might be one you want to think about a little bit more than you had. All right, so I think we've covered what we have, and hopefully we haven't put you all to sleep. We hope you will reach out to us if you have questions, and also join us on May 11th for our webinar on telemedicine with Ryan Johnson and Catherine London. Thank you.
Thank you very much.